My name is Clase. I'm an associate professor at McMaster University, and I had the con side of the debate about whether to use anticoagulation for patients with low kidney function and people on dialysis who also have atrial fibrillation. So my arguments basically were that when you look at our use of warfarin across the world, what we find is that the use of warfarin varies by country, and when we see that, we're fairly convinced that we're not looking at something that's based on evidence. We're looking instead at something that's culturally bounded and based on familiarity. The next point that I really want to make is that it's much more difficult to use warfarin in people on dialysis than in people who are not on dialysis. This is really important because we know that how well warfarin is used is a very powerful predictor of the complications people get. We also know that it's a powerful predictor of efficacy, and when warfarin is not tightly controlled, we know that people actually have less benefit from warfarin in the sense of having more ischemic strokes. I'm going to move on now to talk about actual outcome data, and the outcome data are harms, and for harms we have bleeding and calcification. When we start looking at studies in people with low GFR and people on dialysis, the studies are really very poor and they're very hard to put together. So the best way I can summarize them is to say that the risk of bleeding is probably increased, maybe very much increased. It's certainly increased because of the low GFR. It's probably increased because of the warfarin. The magnitude of that increase is actually not known, and that makes it very difficult when you're considering risk-benefit ratios and trade-offs between benefit and risk, that we don't actually have a good method of assessing that risk in dialysis patients. But the risk of bleeding is high, and the risk of bleeding is increased by warfarin. Think about this argument, because I think when we don't know about something, we don't usually just conclude that it's safe. And this part of the story is the part about calcification. So this is actually an on-target effect of warfarin. We use warfarin to try and prevent coagulation proteins from being synthesized. And in exactly the same way, warfarin prevents matrix Glar protein from being synthesized. Well, why does that matter? Because matrix Glar protein is an active inhibitor of calcification. And we know that calcification is an active metabolic process that occurs when vascular smooth muscle cells dedifferentiate and start behaving like bone cells. And we know that matrix Glar protein reduces that calcification, and that warfarin reduces matrix Glar protein. So there's very good reason to think that warfarin might be a promoter of calcification. However, when we start looking in dialysis patients for that evidence, the evidence is really absent. We have some case control studies looking at the risk of soft tissue calciphylaxis in patients on and not on warfarin, and certainly cases were more likely to be on warfarin than controls. But what we really care about, I think, are the arterial calcification, the valvular calcification, the coronary artery calcification. We know these are problems in dialysis patients. We know that these are all factors that are associated with major increases in morbidity and cardiovascular disease. But we have no data at all that examine whether warfarin may be part of the causal pathway in those patients treated with warfarin. So the final thing that we need to talk about then is, under outcome, is stroke. Stroke is the thing that we fear the most in these patients. It's the thing that patients fear, and if anything, patients probably fear it more than we do. But the trouble with stroke and warfarin is that when we come to look at the dialysis patients, all we have are observational studies, and those observational studies do not suggest that we are likely to see a strong benefit from warfarin. The story got started with Kevin Chan's publication about 4 years ago now of a study suggesting that warfarin was actually associated with an increased risk of stroke. This was followed by a study by Wiseman, which suggested that there was probably no increased risk for many patients, but those above 75 might suffer an increased risk of stroke with warfarin. There was no signal of benefit in either of those studies in any subpopulation. Winkelmeyer went on then to do the third study, and the third study was methodologically the best of the three in dialysis patients. And in that study, what was observed was absolutely no benefit. So to find absolutely no signal of benefit at all in the best conducted of these studies, and a suggestion of harm in other studies, is very damning. The fourth study was published late last year in the New England Journal. It's a Danish registry study. The first author is Olsen. In that study, what was observed was that in the general population, well, included in this registry study, there was a benefit from warfarin, not as great as you'd expect in randomized trials, but that's what you would expect to see when you go from a trial population to a general population. We also noticed that for CKD patients, people with a CKD diagnosis, it's not really clear what that diagnosis meant in the study, that there was an attenuation of benefit. Now, I would say that this is the last and latest study published, and people might say, well, it's a definitive answer, but actually I don't think it is the definitive answer. There's only 900 patients in the study. The studies by Chan, Wiseman, and Winkelmeyer included more than 6,000 patients altogether. The Olsen study is not consistent with those data, and it's also not internally consistent, because if you see an attenuation of benefit in CKD not on dialysis, then you'd expect to see a further attenuation of benefit in patients with CKD on dialysis, and not a magnification of benefit. So I think that probably the play of chance is affecting those results. I suppose the most important thing I can say in conclusion is we have evidence that it's hard to use. We have evidence of harm in terms of bleeding. We have a good biologic rationale and animal models suggesting harm in terms of calcification. And we have no evidence of benefit. This would be problematic if this was a treatment, and I think sometimes when I've been talking now and earlier today when I was talking, I may have used the word treatment by accident, but this is not treatment. This is prophylaxis. This is something that we are going to patients and saying, you'll be better if you take this. And the level of evidence that we require, or we should require of ourselves, when we offer somebody a prophylactic treatment is higher. It should be randomized controlled trials or systematic reviews of randomized controlled trials. And of course, in the general population, we have all that. But in patients on dialysis, and to a lesser extent in patients with a GFR less than 30, we simply don't have those data.